So today, 25th February 2026, respected faculty members, dear colleagues, and my future oral pathologists who are young generation are undergrad students. Good afternoon to everyone. I, Dr. Bhuvan Nagpal, welcome everyone to today's celebration of National Oral Pathologist Day 2026, which is especially meaningful because it is centered around you, the undergraduate students who represent the future of oral pathology and the future of diagnostic healthcare in India. Oral pathology is not just a subject in your syllabus, it is the science that converts clinical doubt into diagnostic certainty. It is the foundation of cancer detection, disease understanding, and evidence based treatment. Scientific evidence across the world clearly shows that early microscopic diagnosis significantly improves patient survival, reduces treatment complications, and strengthens healthcare outcomes. As this powerful responsibility rests in the hands of oral pathologists. Dear students, you are not preparing merely just to pass exams, you are preparing to become diagnostic decision makers. The most important perspective I would like that everyone should imbibe today is that oral pathology is far beyond reading textbooks. Yes, textbooks give you information, but microscopes give you understanding, slides give insight, clinical correlation gives you wisdom and knowledge. True oral pathologists think, analyze, interpret, and integrate science with patient care. The creative competition you are participating in today beautifully it's this deeper understanding where science meets art, observation meets interpretation, and theory meets real oral pathology. At Popma, we strongly believe in nurturing students into confident diagnostic professionals, not just degree holders. The future will demand oral pathologists who are skilled in histopathology and cytopathology, biopsy procedures and FNAC, laboratory diagnostics, digital pathology, artificial intelligence tools, clinical correlation, and research. And you will be the generation that leads this transformation. I would like to give a special mention to Dr. Kiran Jadhav sir, who is the chairperson for this event, whose constant encouragement towards student learning and academic innovation has played an important role in shaping young minds in oral pathology. I also sincerely appreciate our General Secretary, Dr. Shivani Mungla, for her continuous efforts in strengthening academic programs and creating opportunities for students to grow beyond classrooms. Dear students, your attitude today will define your excellence. Be curious, be analytical, look beyond notes, ask why a lesion behaves the way it does. Understand patterns, not definitions. If you start thinking like a diagnostician now, you will become leaders in healthcare tomorrow. Popma stands with you in this journey to guide you, mentor you, and create platforms where your talent is recognized nationally. On this National Oral Pathologist Day, I urge each one of you to embrace oral pathology not just as a subject, but as a powerful clinical science that saves lives. You are the future of this specialty, and the future is extremely bright. Wishing all of you success, inspiration, and a lifelong passion for diagnostic excellence. Thank you so much. Jai Hind and Jai Oral Pathology. Now I request our chairperson, Dr. Kiran Jadhav sir, to start with the program and introduce our judges. Over to you, Dr. Shivani, for all the backend support and other things. I welcome Dr. Shelly Arora ma'am, Dr. Shipra ma'am, and Dr. Shalja Chatterjee ma'am. Thank you so much for giving your precious time and evaluating the young minds and their creativity and innovation. Thank you so much.
Okay. Good evening, all. Good evening, everyone. Good evening, the judges, respected judges. It's a proud pleasure for me to introduce the judges for this today's event, sort of a competition, what we had thought of, and it is like focusing mainly on the undergraduate students for their artistic skills and their imaginations and thoughts in relation to the histology and oral pathology subjects. So this competition is unique in itself, and for this competition, for the uh, judging, we have today the three esteemed judges. First, Dr. Shipra Deshpande. Dr. Shipra Deshpande madam has completed BDS from GDCH Aurangabad and MDS from Provara Institute of Medical Sciences Loni, and currently she is also pursuing PhD at GDCH Nagpur. She is a certified tobacco cessation specialist. Her areas of interest are oral precancer and oral cancer, and presently she is working as professor at Dr. Edgewar Dental College and Hospital, Hingoli, Maharashtra. She has more than 14 years of teaching experience, and she has numerous publications and presentations to her credit. She has also received grants for the project on oral precancer and cancer. She has 5 copyrights registered and 1 international and 3 patents registered on her name. And she has also published a chapter in a textbook published by the Springer Nature. She is a life member of Indian Association of Oral and Maxillofacial Pathology, then our own association, that is Practicing Oral Pathologist and Microbiologist Association, and member of Indian Dental Association Nagpur branch. She has worked on various social and cultural projects and activities. I welcome Dr. Shipra Deshpande madam for the judging for this competition, and thank you for accepting our invitation.
Thank you, sir.
Yeah. The second judge is my own friend, Dr. Shaili Arora. Dr. Shaili Arora is a senior lecturer in oral pathology at the International Medical University, Malaysia, with over 15 years of academic and research experience across India, Malaysia, and New Zealand. She holds a PhD in oral biology from the University of Otago, where she was awarded a competitive international doctoral scholarship. Her research focuses on dental pulp, immunology, inflammation signaling pathway, and vital pulp therapy, and many more molecular aspects. She has authored over 50 peer-reviewed publications in international journals, including the International Endodontic Journal and the International Journal of Molecular Sciences, and has contributed chapters in Willy and in Springer Journal. Dr. Shelley has secured competitive research funding in Malaysia, New Zealand, and India, and serves as a peer reviewer for international journals. Her work integrates translation oral biology with higher education research and academic leadership. So I welcome Dr. Shelley. Dr. Shelley, madam, are you there?
Yes, yes. Can you see me? Hi, Kiran. How are you? Thank you.
Yeah,
Oh my
fine.
God.
And I welcome you and thank you
Thanks,
for
thanks.
accepting our invitation.
Thank you,
And we
Kiran. Thank
have
you. Happy.
one more judge, Dr. Shailaja Chatterjee, madam, who is a senior oral pathologist in our fraternity. Dr. Just a minute. Yeah, Dr. Shailaja Chatterjee, madam, has completed BDS from Manipal University in 2002, sorry, and then MDS from Manipal University same in 2007, and she has also completed PhD from MMTU Haryana and currently working as professor and head Department of Oral and Maxillofacial Pathology at Yamuna Institute of Dental Sciences and Research, Yamuna Nagar, Haryana. She has total experience of around 18 years and she has more than 50 publications to her credit, and she has presented papers at various scientific platforms. I welcome you, Madam, Dr. Shailaja, Madam. Are you there?
Can you see me? Am I seen?
Yes, you are audible, ma'am. You are audible.
Can
Yes,
you
ma'am.
see me
Yes, ma'am.
clearly now?
Yes, ma'am. Yes, ma'am.
Yes. Okay, welcome, madam. Welcome. So now all the judges, we have circulated the evaluation sheets to you, and you can evaluate the students according to the criteria. We will be giving 2 minutes for the presentation to each student, and then 1 minute will be for the discussion sort of. So I request the students to stick to the time and just talk about your drawing or whatever you have done the artistic work. So all the best for all the students. So we'll start with the first student. Just a minute. Hello. Dr. Shivani, are you there?
Yes, sir. I'm there, sir.
Just can you share, can you just open up those PDFs? Because it is
Yes, sir. Now,
difficult for
sir,
me now.
just after that double click, sir,
Yeah.
you please click always and it will just keep on coming, sir.
Okay.
Yeah, yes.
Always. Okay.
Ji, sir.
Yeah. Is it same
Yes, sir. Yes, sir.
always?
Now, yes, sir. Now just always.
Yeah.
Yes, sir. It has come. Sir.
Okay. Fine. So first number is present. 001. Yes.
Participant number 001K.
Participant number 001K. Are you there? We'll go to the next.
Maybe ask the person, sorry to interrupt, maybe ask the person, sometimes they mute themselves. So I think just tell the message, have you muted themselves? Just, sometimes students, they don't realize.
Yes, sir. Ma'am, I'm just seeing if the person is there, ma'am.
Sure, please.
No, ma'am. The student has not joined, ma'am. Sir, I think Kiran sir, you can go to the next person.
One.
Yes, sir. Yes, sir.
Okay. Just a minute. Second one, are you there? 002K.
Yes, sir, I'm present.
Yes. So you can start.
Sir, kindly display the picture. It's not visible.
It's not visible.
No, sir. I think, sir, you haven't clicked 2 times, sir. There. Double click is remaining.
Okay. Just a minute. Now,
Now we can see the screen, sir, but the drawing hasn't opened, sir.
drawing is not opening.
No, sir. Sir, you want me to do, sir?
Yeah, please. Please do it from your side. No problem.
1 second, sir. Is my screen visible?
Yes. You have started sharing the screen. That is what message we can see now.
Sir, now the drawing is also visible.
Yes.
Yes, now I can see. Yeah.
Yeah. The participant 002K, you can start presenting.
Okay, ma'am. So, in this particular drawing, I have shown the adenoid cystic carcinoma's cribriform or Swiss cheese pattern. We see the tumor islands in the corners of the drawing. I have presented the tumor islands, which are composed of the basaloid cells. This particular carcinoma is usually seen in the parotid gland, submandibular gland, and intraorally in the tongue and palate. So we see these tumor islands that are present. It is a ductal cell carcinoma. It is ductal cell carcinoma along with myoepithelial cell. So in cribriform pattern, we mostly see the myoepithelial cells which have been shown here through the tumor islands and epithelial nests. And they have this punched out appearance with these cystic form that we are seeing. These cysts are pseudocysts, which I have also marked. These pseudocysts contain mucopolysaccharide material, and I have shown the collagen bundles which are present in the stroma. The stroma is hyalinized due to the release from these tumor cells, and the classic feature of adenoid cystic carcinoma is the perineural invasion of the tumor cells. I have shown the nerve bundle here, and along with the tumor cells invading into it. This drawing that I made was done with the eosin and hematoxin pencils so that I could give the correct H&E staining. And additionally, I have zoomed in a part of the tumor island to show the cribriform pattern in a better way with the basaloid tumor cells zoomed in along with the gaps that are present caused due to the secretions of these gaps are filled by the mucopolysaccharide material which the tumor cells are secreting, and this whole stroma is largely eosinophilic, and there are basophilic granules which I have tried to show by a few dots throughout. And I took this picture from a journal because I wanted to show the whole picture along. Usually we see the zoomed in picture of the tumor island, which is present in Schaefer's or Neville. I wanted to show all the classical features in this case.
Judges has any question to ask?
You, Asmita.
Thank you.
I have one question.
Yes, ma'am.
What is the nature? How do you describe a cell in administrative carcinoma? One cell.
These cells are majorly, they have scanty cytoplasm. The nucleus is large, basophilic in nature. Um, yes,
Okay.
basophilic in nature.
Okay.
Thank you.
Yes.
Sir, I'll be presenting the next participant.
Next, yes.
Is it 005?
Hello. Yes, I am
Yes.
present, ma'am.
Yeah, you're present. Just a moment. Give me 1 second, please.
Yes, ma'am.
Can you see the drawing?
Not yet, we can
Not yet, ma'am.
not yet see.
Okay. Now.
Yeah, yes.
Yes, ma'am.
Can you just rotate it?
Yeah. 1 second. 1 second. Just it's coming very slow. No, sir, I'm not able to do it.
Mhm. Anyway, I think let her present.
Screen share is just show. 1 second, sir. I hope my screen is visible now.
Yes.
Yeah. I think you can start.
Yes. We can see now correctly.
Yes.
Yes.
Hello, sir. Hello, ma'am. Am I audible?
Yes.
Yes, you're audible.
Very good evening to everyone. So, this I am presenting. This is basically a journey of one small chief of a tobacco. So it starts with the normal mouth, with a normal epithelium. That is, we can see that the stratified basalis, spinosum, granulosum, corneum, all the cells were well arranged in healthy oral mucosa. But when tobacco, alcohol, smoking enters repeatedly, they don't just stain the teeth, they attack the DNA and mutation begins the silently. So now the warning stage arises when the cells forget its discipline and they lose their polarity, they multiply abnormally, and that leads to the dysplasia. So what we can see clinically is that it may appear as a leukoplakia. So where we can see that lower one third of the epithelium, cellular pleomorphism can be seen, that variation in size and shape of the structure of the cell, or oral squamous fibrosis, where the mouth slowly becomes stiff only due to the deposition of the collagen fibers. So basically, leukoplakia arises because of the tobacco chew, where chronic irritation occurs and epithelial hyperplasia occurs, and then DNA mutation, which leads to epithelial disorder, where oral squamous fibrosis, which occurs because of the erica nut, and nutrient deficiency like iron and B12, where excess production of the collagen occurs. That's why degradation and more collagen production, which leads to connective tissue disorder, and it is the and both leukoplegia and OSMF can be lead to the oral squamous cell carcinoma. So oral squamous cell carcinoma in histopathological studies, we see that there is a formation of a keratin pulse and cellular pleomorphism, nuclear hyperchromatism, are some histological features. Also, it may lead to facial nerve palsy through the parotid gland, and perineural lesion may occurs. And all such histopathological studies that we see under the microscope, and we call it as a biopsy. So cancer is not just an accident, it is the biological consequences which arise due to tobacco, alcohol, because they contain nitrate, nitrosamines, which are carcinogenic, alcohol, which contains the which converts into the acetaldehyde, which is again carcinogenic. It is promoter, and smoking leads to the lung disorder, that suppress the that mutate the suppressor gene, and all such things leads to the cancer of the facial region. Main factor is the stress that day-to-day life, almost 20 to 30% of the cancer patients uh, are only can be seen because of all these reason like stress and junk food. So basically every chief writes our own biopsy. Yes, sir. Thank you.
Thank you, Purva.
Thank you.
Yeah. Judges, any questions?
Can you tell me about anything about field cancerization? What does it mean?
Sorry, ma'am, which?
Field cancerization.
Field cancerization.
Okay.
Sorry, ma'am.
What is which cell is the chief regulator of cell? Which molecule is the chief regulator of cell cycle? Master of genome?
There are some promoters like acetaldehyde and nitrosamine nitrate.
Not chemical generated. I'm talking about the genomic component. Which genes? They get mutated when somebody takes tobacco.
Mhm. No, ma'am. Sorry.
Okay.
Judges, any other questions?
Yes, Kiran, I want to ask one. Hi, Purva. Thank you for your presentation. I like the way you presented the picture. So now when you're showing your picture in the histopath picture for your oral cancer, can you tell me why you're calling it oral cancer in that picture, in that histopath picture, why you said it is a cancer? Or you can, Shivani, Dr. Shivani, can you please share the screen again?
Yes, sir. Yes, ma'am.
Sure. Thank you.
Ma'am, basically our oral healthy mucosa, which turns into the cellular pleomorphism, and there is a overgrowth of cells, and cells lost their polarity. There is a tumor growth, and that's why there is mutation into the gene, and it leads to the cancer. And I said that it is oral cancer because uh, it is related to the parotid gland lesion, where perineural
Sorry
lesions
to
are
cut you.
also associated.
Relax. Sorry to cut you. I'm not saying that. I'm saying histologically simple. Why you're calling it oral cancer? When do you call it cancer histologically? What is the main thing you see histologically?
The tumor and cells which are abnormally dividing.
So where they're dividing, so there is straight away
They are,
invasion, right? So you have to say
yes, ma'am.
hallmark of all cancer is invasion. There's a break of the basement membrane, right? Which I
Yes,
cannot see
ma'am.
in your
Break of the.
picture. So I can't see in your picture, histological picture,
Ma'am,
right? There's
it
an
is
intake, there's
it
intake
is
basement membrane. Yeah, you're not showing invasion cells are infiltrating, right?
ma'am.
Where is the
I'm
break
shown
in your
oral squamous cell carcinoma picture. There are some cells invading there.
okay, so
They are
but your picture
invading
is
the
not the
basement
correct.
membrane.
Okay, your picture is not the correct presentation. Okay, there's a break. You
Okay,
have to
ma'am.
show it. Cells are infiltrating. Okay, so the hallmark
Okay,
of
ma'am.
cancer histologically is the invasion of cancer cells into the underlying connective tissue. Okay, this is the
Yes,
very
ma'am.
simple thing. You should. Okay, all right. Now you know. All right. Okay, thank you.
Yes, ma'am. Thank you, ma'am.
No problem.
Okay, ma'am.
So, shall we go to the next? So the
Just give me
next,
a second. Just a second. Just want to fill in. Otherwise,
yeah.
Yeah. We can proceed. Yeah, sure. Thanks.
Can we see this? Can we
Yeah.
see the next one? Hello?
Was the number?
Yes, sir.
Yes, sir.
Yes, sir. I can see, sir.
Yes, yes. Okay, so next
Yes.
number is 006K.
Hello, good evening, honorable judges. Am I
Yes,
audible?
yes, you are audible.
Yes,
Continue.
Uh, My today's presentation is regarding the oral squamous cells carcinoma. From where we see like how normal oral epithelia, which are delicate in nature, and how these normal oral epithelia causes the pre-malignant or the malignant tumors. From where the normal oral epithelia, which have multiple layers like a basal, spinosa, and the granule or the superficial, in which their mitotic divisions occur, and basement membrane is intact to it. After exposures to the some risky factors just like a microbiome or the environmental carcinomas in which we see like tobaccos or the alcohols, areca nuts like a good or gutka. Some like risky factors are the they are the chronic irritations, or the genetic susceptibility and the tumor microenvironment, which causes abnormality in normal oral epithelia. If there will be the any factor, uh, there will be the any abnormal factor will penetrate or they will invade the normal oral epithelia. There will be the alteration in the normal oral epithelia, in which first step which we see in the picture is a hyperplasia. There is epithelia of the like oral epithelia are uh, mitotically dividing, leads to hyperplasia. Afterwards, there is the formation of the like nuclear pleomorphism in the epithelia, and the retipics are they are the drop shape, leads to epithelial dysplasia, and the severe dysplasia, which is the pre-malignant stage, leads to carcinoma in situ, in which entire epithelium replaced by the atypical cell. There is no invasion, but basement membrane is intact. Then there is a full thickness epithelium dysplasia. Afterwards, they leads to invasive squamous cell carcinoma. There is the tumor cell breach in the basement membrane, invade underlying the connective tissue. Then it will lead to malignant stage. If there will be the uncontrolled proliferation of keratinocytes, then there will be the severe malignant tumor. We can prevent all these like pre-malignant or the malignant tumor by some factors like UV rays or the betel nut or the alcoholics, and there are some genomic factors uh, which which can prevent the pre-malignant or the malignant carcinomas, like squamous cells carcinomas. Thank you, judges.
Yes. Any questions from the judges side?
Can you list the architectural changes that you see in epithelial dysplasia?
Hello,
Can
am I
you
audible?
list the architectural changes that you see in epithelial dysplasia?
There is loss of tissue organization, and there's a disordered maturation, like increased cell density in hyperplasia, which will be linked to the dysplasia. There's a drop-shaped retinages,
Hmm.
and there's a loss of normal polarity of the basement membrane.
Hmm.
Like there's a high risk of precancerous state by signaling of the like some gene molecules or the genomes.
What is risky epithelium?
Uh, risky epithelium is like these are the uh, they have the high turnover rate to like to divide the continuous or the vigorous strength to divide. If they will expose to the some external factors or the internal like external factors such like environmental or the toxin or such underlying that that are the risky epithelium tissue. मतलब they will try to invade the basement membrane or the breakage of the basement membrane, due to
Hmm.
which some epithelial tissue, which are the pleomorphic cells, invade into the connective tissue, will cause the some chronic or the acute uh, disease or disorders.
Okay,
Okay,
fine.
one thing I want to ask. Is it okay, Shailaja madam? You
Yeah,
finished?
please. Yeah, I'm done.
Okay. Will you label carcinoma in situ as a pre-malignant lesion?
uh, we can denote the like severe epithelial dysplasia at the pre-malignant stage, which carcinoma in situ we also include in pre-malignant stage, but the severe pre-malignant stage have denoted by the carcinoma in situ. There's a nuclear hyperchromatisis, like chromatism visible, which will be in future invade the basement membrane and comes in connective tissue and forms the like tumor cells, like showing the nucleus, like nuclear and the cellular pleomorphism leads to the malignant cancer.
Why it's called as carcinoma in situ?
Because carcinoma in situ, they are the epithelial, matlab, carcinoma has developed from the epithelial lesion. Because of that, we said them carcinoma. There's a group of like abnormal cells. There's a like we see like there's a grades of the cancers like 0 grade, first grade, second, third, and the fourth, where it is referred as a 0 grade cancer, which are non-invasive. मतलब they are not directly or the immediately life threatening stage of the malignancy or the carcinoma.
Okay.
Okay, I guess fine, judges.
Just one thing I want to ask Kiran, if you don't mind. May I
Yeah,
proceed?
please,
Yes.
please.
Hi, Sony. Thank you for your presentation. I just want to ask, you're using the term too often, I realize, pre-malignant and pre-cancer. What is the current terminology we use these days to refer these conditions?
Uh, Pre-malignant. They are the
Yeah,
they have the pre-malignant, it means that they have the ability to
No,
cause
sorry to cut you.
malignant.
Sorry to cut you. Sorry to cut you. I'm not asking that they are pre. I'm saying you are using this terminology a lot. There is a current terminology which we prefer. It is there
Potential,
in the textbook. Yeah, use that. Okay, they're called as
potential
OPMDs, oral.
malignant.
Yes,
Yeah.
oral potentially malignant disorder. Either you say OPMD or you say PMD. Okay, that's what I want.
Yes.
Okay, good.
Yes.
Yeah,
Thank
thank you.
you.
Thank you. Now we'll go to the next.
Kiran sir, you just stop the
Yes,
screen sharing. I'll share the screen, sir.
yes. Okay. Yeah. Now, just I want to say here, all the students, whoever is presenting, just tell in which class you are. Okay, whether in first year BDS or second year BDS, third
Yeah,
year.
that will be better.
Sir,
Okay,
Yes,
yes,
that will be
so
better.
that will
that
be better.
our judges
We
will
have an
ask the questions
correct.
accordingly. Just a request, okay, to all the students. Yeah. So next presenter.
008K, are you there? Sir, is my screen visible, sir?
Good evening, ma'am.
Yes, Shivani, I can see. Thanks.
Oh, okay. Thank you.
Screen is too vibrant now.
I just concise all the drawings so that it can be visible, ma'am.
Yes, visible.
Yeah,
Can you just
008K.
enlarge it? Can you just
Good
enlarge
evening,
it?
ma'am.
It's like it's going beyond that, sir. I mean, if I enlarge, I'll
Okay,
try.
okay. Fine. No problem. No problem. Start. Presenter, you
Start the
can.
presentation.
Good evening, all. Good evening to the judges. I'm Pavitra Vijay Kumar, currently doing third year BDS. I'm here to present the topic on pemphigus. Pemphigus is an autoimmune, serious, life-threatening chronic skin disease, in which the manifestations are usually seen in the oral cavity and the skin. To brief on the pathogenesis, uh, the body produces auto antibodies against the desmoglein 1 and desmoglein 3, which are the major proteins of the desmosomes, which are reason for the intercellular adhesion. Where the auto antibodies produced against these two proteins, the loss or the bond between the cells get interrupted. So acantholysis happens between the cells. The first half of the image, where I try to depict the direct immunofluorescent testing of the pemphigus vulgaris, in which direct immunofluorescent testing helps or it plays a major role in the diagnosis of pemphigus vulgaris. It helps to demonstrate immunoglobulin G predominantly, and also in combination with other immunoglobulins like IgA, IgM, and forms the characteristic chicken wire or the fishnet pattern. To note here is that only there is an epithelial bond breakage between the intercellular layer, not between the cells and the basal cell layer. So there is a characteristic suprabasilar splinting happens, in which there is a space formed between the basal cell layer and the above acantholized layer. And coming into the HNE, the eosin and hematoxylin staining, the most prominent feature is the presence of Zang cells. It is not an of diagnostic value because it is also found in other vesiculobullous lesions like herpes simplex, varicella zoster. So it is usually found in all the vesiculobullous lesion. As like here, pemphigus is also an vesiculobullous lesion. Zang cells are also seen here. And as I said before, there is no problem between in the hemidesmosomes, which is an intercellular connectivity in the basal cell layer. The basement membrane remains intact, and a characteristic tombstone appearance is seen. Just beneath the basement membrane, you can see the infiltration of the inflammatory cells, which normally denotes the inflammation, and all the other characteristic feature is normal to an inflammatory condition. Thank you. And to note it, the title I given to my drawing is Acantholysis, the silent separation, as the separation here is very silent. And the reason why I took this topic is histopathology plays a major role in the diagnosis of pemphigus. Before the clinical feature or clinical manifestation seen orally, it is easy for us to diagnose with the help of histopathology. So my title is Acantholysis, the silent separation. I have given my references in the bottom of my drawing. Thank you for this opportunity. Thank you, ma'am.
Very good drawing, very good presentation. I just want to ask a couple of questions. Like, what is the exact pathogenesis of pemphigus vulgaris?
Ma'am, actually, the problem is with the intercellular adhesion materials, which is called as the desmosome. It is made up of proteins desmoglein 1 and desmoglein 3. Where our body produce auto antibodies against these important proteins. So it leads to the breakage of the integrity, leading to the separation of the cells, ma'am. To be more specific, desmoglein 3 and desmoglein 1, where the auto antibodies produced against desmoglein 1 and 3 leads to mucocutaneous lesion, where the auto antibodies produced against desmoglein 3 causes mucosal lesions, which are commonly seen in the oral cavity, ma'am.
Okay. Can you tell me what is a salt split skin technique or test?
Uh,
Salt split skin test.
no, ma'am, I'm actually not sure about that.
Can you tell what is indirect immunofluorescence? You are talking about direct immunofluorescence. If you can shed some light on indirect immunofluorescence and salt split skin technique, that will be beneficial to you. At times, it is not possible to make a biopsy. So, what is the other tissue that you will look for in human body, which can be tested more freely?
Uh, Ma'am, are you asking about whether if we are not able to take an oral biopsy, what is the possible
Yes.
thing?
So, in that case, you do indirect immunofluorescence. What is the sample type of sample that is taken? If you don't
Uh,
know, you say so. You read some because I think Schaefer's only gives about direct. Direct is
yes,
not
ma'am.
mentioned. No
Yes, ma'am. I
problems.
went through Schaefer's only, ma'am.
I know. What is Zank test?
Zang test is like, as I mentioned previously, the epithelial remnants leads to the formation of giant multinuclear cells, ma'am. Where you in the area of that bullous or vesicle, when we give a lateral pressure, it leads to the formation of bubble over the skin.
What is it called? What is the sign called?
Um,
This is a test. What is it called? Clinical examination. You do that if you suspect pemphigus or any other similar vesicular bullous lesion.
we usually do Nikolsky sign test, ma'am.
Okay. Okay, done. Good.
Yes, ma'am.
I'm done. Okay. Read about indirect immunofluorescence, but
Sure, ma'am. Sure, ma'am.
Any other question?
Hi, thank you for your presentation, Pavitra. I just want to ask, this picture, you have drawn it, or is just because how is it? Is you have taken the picture from somewhere?
No, ma'am. Actually, I was about to draw a diagram on pemphigus only, ma'am. It was an incitement given by my staffs to incorporate it with the direct immunofluorescence. So it was drawn by me, ma'am, but the ideology was by my staffs.
No, that is fine. But I mean, so this you have drawn it. I just want
Yes,
to know
ma'am.
that.
Yes,
That's it.
ma'am. It's an hand
Okay.
drawn thing.
Okay. Okay. All right. Good. Thank you. That's it.
Mm,
Thanks.
thank you.
Can we move to the next presentation, ma'am?
Please
yes,
move.
please.
009.
Yes, ma'am, I'm here.
Yeah. You can start the presentation.
Yes, ma'am. Good evening, everyone. My artwork is titled Invasion Beyond the Basement Membrane. It illustrates the most decisive histopathological event in oral squamous cell carcinoma. Actually, the oral carcinoma is strongly associated with risk factors such as tobacco use, alcohol consumption, and chronic irritation. These factors induce genetic mutation that disrupt normal cell cycle regulation, including alteration in tumor suppressor genes like P53, leading to progressive epithelial transformation. Okay, on the left side of my artwork, I have depicted normal stratified squamous epithelium. The cells are orderly and uniform, resting on an intact basement membrane, which act as a structural and biological barrier separating the epithelium from the connective tissue. As we move toward the center, dysplastic changes become evident. There is cellular pleomorphism, nuclear hyperchromatism, loss of polarity, and increased mitotic activity. Although the cells appear abnormal, they are still confined above the basement membrane, representing a carcinoma in situ. The most critical event shown in my artwork is the breach of the basement membrane. Once tumor cells penetrate this barrier and invade the underlying connective tissue stroma, the lesion becomes invasive carcinoma. In the connective tissue, I have illustrated tumor islands with a keratin pile formation, indicating a well differentiated squamous cell carcinoma. I have also represented inflammatory infiltrate and stromal response, reflecting the host reaction to tumor invasion. This breach marks the biology. Sorry.
Nothing. Please continue.
This breach marks the biological point of no return, as it allows tumor cells to access lymphatic and vascular channels, increasing the risk of metastasis. Uh, Through this artwork, I aim to visually capture the transition from normal epithelium to invasive malignancy and emphasize the importance of early diagnosis. Thank you.
Thank you so much.
Thank you.
What is Bobin's disease?
Ma'am, can you repeat again?
Bobin's disease.
No, ma'am.
You're in which year, beta?
Ma'am, third year, ma'am. Third year.
Third year. So tell me what's Bobin's disease? BOWEN apostrophe S. Bobin's disease. Don't know?
Ma'am, could you repeat the spelling again? Ma'am? Bubbles?
BOWEN. Bobin's. Are you typing?
Bubbles?
Don't Google it. If you don't know, say so.
No, ma'am. No, ma'am, I don't know.
You don't know?
Yeah, ma'am, I'm not sure about that. Ma'am.
Okay. So what exactly is the mechanism of keratin pearl formation? You have shown such a nice keratin pearl in center. Can you tell me how it is formed? See, these are the questions that you must know. Because keratin pearls, apart from squamous cell carcinoma, can be seen in other lesions also. Can you tell some examples?
No, I'm not sure.
Okay. No more questions from our side.
Any other question we have? Yeah. Shipra madam, yes, tell.
Can you tell me the histological grading for squamous cell carcinoma? Because you have shown the nicely this keratin pearls.
Yes, ma'am. Ma'am, once again, repeat the question, ma'am. I didn't catch.
Histological grading for squamous cell carcinoma.
Yes, ma'am. Well differentiated squamous cell carcinoma, less well differentiated, and poorly differentiated carcinomas, ma'am.
Will you label it as poorly differentiated?
It's a well differentiated one, ma'am. It's obviously we seen mitotic figures and keratin, numerous epithelial or keratin pearls. So it's a well differentiated. It's a well differentiated squamous cell carcinoma, ma'am.
Can I move on to the next question?
Yeah.
Thank you.
Just a minute. Just a minute. All the presenters, please stick to the time. Okay, do not exceed the time so that we can finish it within the time. I request all of you to finish your presentation within the time. Yeah. Please
I
continue.
think if somebody is exceeding, the presentation can be cut short. Because I feel there's a couple of them have exceeded.
Yeah. That is why actually I am just telling them to cut short your presentation and finish it within 2 minutes only.
Okay.
0011.
Yeah.
Yes, ma'am, I am here.
Yeah. Start.
Yes. Today I am going to speak about radiculocyst, ma'am. The most common odontogenic cyst of the jaw. Radiculocyst is an inflammatory cyst that developed at the apex of the tooth. It arises as a result of pulp necrosis, usually due to dental caries or trauma. It's only I show in my picture, ma'am. Because it is associated with the root of the dead teeth, it's also called periapical cyst. Pathogenesis begins with the deep dental caries or trauma, leading to pulpal infection and necrosis. This infection spreads to periapical region, causing chronic periapical inflammation. The inflammation process stimulates the epithelial rest of molluscs present in the periodontal ligaments to proliferate. Over time, this epithelium cells undergoes cystic degeneration and form a cavity lined by epithelium. This become radicular cyst. Clinically, radicular cysts are most common in adult, especially in third and fourth decades of life. Radiographically, the radicular cysts appear as a well-defined round oval radiolucency at the apex of the non-white tooth. It's usually a corticated margin unless it is infected. Histologically, the cyst is lined by non-keratinized stratified squamous epithelium of variable thickness. Epithelial shows spongiosis and inflammatory cells infiltration. Proliferating epithelium exhibits characteristic arcading patterns where arcades of epithelium encloses densely inflamed connective tissue. Connective tissue capsule may also show cleft-like space filled with cholesterols that are seen as a spindle-shaped space. The presence of these cholesterols evoke granulomatous reaction in the connective tissue. I selected this topic because I am a new third year student. I have just started seeing patients 2 weeks ago. I saw a 52-year-old female patient. She had root stems associated with radiculocysts. After seeing the cases, I become more interested in learning about it in detail. This is why I choose this topic so I could understand it better and gain more knowledge about this diagnosis and management now.
Thank you so much for presenting.
One thing that you could have demonstrated in this diagram are Rushton bodies. Yes or no?
Yes, ma'am. I missed that.
What are Rushton bodies?
Western bodies is a hyaline body, ma'am. It's a tiny linear or arcadic shaped bodies, ma'am, which are reflected and non-bifringent.
How do these cholesterol clefts form, which you have shown in your picture?
Yes, ma'am.
Derivation of cholesterol.
In
here.
It's why it's because of the deposition of fats or some lipid content in that area, ma'am. It's not visible.
Why would you call them cholesterol then if fat is getting demonstrated? Fat and lipids are entirely different things. Fat is fat. Fat cells, you know how fat cells look under the microscope? Nice lobules with centric nucleus, adipocytes. These are quite clefty. So these slits, so why you're getting these slits? What is the shape of a cholesterol crystal? Do you know what is a wet mount? Have you
No,
heard about
ma'am.
wet mount?
No.
Okay, no problem. Okay.
Yeah.
Yes, Rajeshwari, what
Yes,
you
ma'am. Yes,
get on the
ma'am.
aspiration of this is if you do the aspiration side for
I'm not here, ma'am. Please again repeat it. Ma'am. Hello.
voice is not clear.
Yes, ma'am. It just cracked, ma'am. Now you're clear, ma'am. Please ask the question again, ma'am.
On aspiration strategy, what you will get in radicular cyst?
I mean, histological or pathological, ma'am.
No. Ma'am is asking in aspiration cytology.
Okay. Ma'am, lumen
Having
contains the cystic lumen contain the fluid, ma'am. I mean, it's
On
actually,
cytology, what you will get it?
ma'am.
Can I start? Can I
Ma'am?
ask, please?
Yes, ma'am. You can ask, ma'am.
Okay. Hi, Rajeshwari. Thank you for your presentation. How does this cyst expand? It is in the bone, right?
Yes, ma'am.
So how does it enlarge?
Ma'am, and that inflammatory cells are other things contain some proteins or enzymes, ma'am. That degrades the bone. That leads
What are
to
those? What are those in? No, it's not inflammatory cell. There are some molecules. You're right. There's some of
yes,
the
ma'am.
molecules secreted in the
Cytokines, interleukins, and the inflammatory osteolytic actions it causes.
there's some other mechanism as well. There are 3, 4 mechanism that you study. Okay. What
Yes.
is a residual cyst?
It's after extracting the tooth, that bony area, that socket forms the residual cyst on that area, ma'am.
Basically, the cyst which is not removed at the time and it's still remaining in the jaws, right?
Yes, ma'am.
Okay. Okay. All right. And how do you classify radicular cysts? You know that we have a classification of cysts. So it comes under which category? You know, WHO classification, we classify the cyst as odontogenic, non-odontogenic, developmental,
Yes, ma'am. It's
inflammatory.
a
So this
odontogenic cyst, ma'am. Odontogenic,
odontogenic.
inflammatory cyst, ma'am.
Yeah, good, very good. Okay, good. Thank you, Rajesh. Yeah, that's all from my side.
Next.
Can I show the next?
Yes, please. Yes, please.
ID number 14K.
Hello.
Hello.
Ma'am, is it
Are you
audible?
aware? Yeah.
Good evening, everyone. I thank everybody of you all for giving me this wonderful opportunity to take part in this competition. So today I'll be talking about my drawing, which is on orthokeratinized odontogenic cyst and emphasizing on its beautiful histology. This cyst, as we all know, is a developmental odontogenic cyst, which was considered as a variant of the odontogenic keratocyst, but now being considered as a separate entity because of its distinct histopathological features and much less aggressive behavior. So this occurs in young to middle-aged adults with a male predilection, commonly involving the posterior mandible, and radiographically appears as a well-defined unilocular radiolucency. It usually is associated with an impacted tooth. So histopathologically speaking, the lining epithelium is thin and uniform, made of stratified squamous epithelium, and the surface shows orthokeratinization. And this orthokeratinization is actually like laminated keratin flakes, which show an onion skin appearance on histopathological slides, which seemed so beautiful to me that made me draw this one. And keratin layer being the most important feature of this cyst. This keratin is orthokeratin, which is thick and laminated.
And in histology about the epithelium, it shows a very prominent granular cell layer. And this onion skin appearance of the orthokeratin looked like beautiful ribbons to me. So I thought, why not a girl dancing with a ribbon can be drawn? So I chose to draw this girl. So that's how I came up with my painting. Thank you for giving me this opportunity. Thank you.
Thank you so much. It was a pretty thought.
Thank you, ma'am.
Judges?
Yeah, the fairy look little odd to me, but then it's fine. Can you tell me, it is the intraosseous, is it a true odontogenic lesion? Is it a true odontogenic lesion? Because it's said to be the counterpart of something extraosseous. What is it?
Ma'am, I'm sorry. Can you repeat your question?
An orthokeratinized odontogenic cyst is considered to be a counterpart of an extraosseous soft tissue lesion. So how can you say it's odontogenic?
Because it originates from the epithelial remnants of dental lamina.
So why is it called the intraosseous counterpart of epidermoid cyst?
Because it represents like a dentigerous cyst with orthokeratinization.
No. Epidermoid cyst, not dentigerous cyst. How is this biologically different from OKC? Odontogenic keratocyst?
It has a parakeratin. Odontogenic keratocyst has parakeratin, ma'am. And this shows orthokeratinization, and it is a more aggressive. Odontogenic keratosis is more aggressive than orthokeratinized odontogenic cyst. And orthokeratinized odontogenic cyst is not associated with Gorlin-Goltz syndrome. Whereas
age of presentation of OKC, at what age groups it presents itself, and at what age group this particular disease presents itself?
Third to fourth decades of life.
Which one?
Orthokeratinized odontogenic cyst.
Third to fourth decade, no, slightly younger. And what about odontogenic keratocyst?
It could occur at any age.
Actually, age-wise, you have gone wrong for both. Anyways, any other questions from other judges?
Shall I move to the next presentation?
Yes, please.
Double 015.
Present here, ma'am.
Yeah.
Am I
Can
audible?
you please start? Yeah, you're audible.
Good evening, one and all present here. Today I'm going to present about an adenomatoid odontogenic tumor. This adenomatoid odontogenic tumor is also called as adenoameloblastoma, which is an uncommon, non-invasive, benign tumor of odontogenic origin. The adenomatoid odontogenic tumor is also called as two-thirds tumor because two-thirds of it occur in females of less than 20 years of age, and two-thirds of it occur in the maxilla, and two-thirds of it is associated with the non-erupted or the impacted canines. Before going on to the microscopic features, this tumor has the diverse histomorphological features.
multinodular proliferation of the spindle, cuboidal, and columnar cells in a variety of patterns, which is forming a rosette-like structure. There will be the presence of eosinophilic material, and there will be calcification seen. The most distinctive feature of adenomatoid odontogenic tumor is a scattered duct-like structure with lumina of varying size that are lined by the single layer of the cuboidal to the columnar epithelial cells, which are having the nuclei that are polarized away from the lumen, that is towards the basement membrane. Then that's all about the microscopic features. Then I'm here to say something about the drawing, why I have selected the Starry Sky painting. This is a painting which is given by the famous painter Vincent van Gogh. And his favorite flower is sunflower, but mine is rose, so that I gave the rose-like feature in my drawing. Then the rose can be, I would like to give a title for this rose as the bloom wall. And for the starry sky drawing, I would like to give the title of Galactic Balls of Adenomatoid Elegance. Here, the starry sky is giving a rosette pattern, which is linked through some duct-like features. Then the calcifications which are present in the histopathological feature can be considered as the stars. Then then coming on to the bloom wall, the rose I have drawn. Then the rosette-like pattern I have given. Then the stem is considered as the duct. The globe around can be considered as the encapsulation by the connective tissue. The shimmer that is from the rose, it may be considered as the it may be considered as the calcification. Then because of the two-thirds tumor, I have divided the drawing into three parts. Thank you. That's all.
It's a nice pictorial description. You have described the tumor very beautifully.
Thank you, ma'am.
Very good. No questions.
Thank you, ma'am.
Yes,
Any other
Sangamitra.
questions, Ajay?
Yeah.
Yeah.
Hi,
Ma'am.
Sangamitra. Yeah. Thank
Ma'am?
you for your presentation. Yeah. Can
Thank
you
you,
hear me?
Ma'am?
Can you hear me, Sangamitra?
Ah, yes, ma'am, you are audible.
Yeah, okay. Hi. Thank you for your presentation. I
Okay.
you said adenomatoid odontogenic tumor, also called adenoameloblastoma, right?
Yes, ma'am.
Are you sure that this is the
Ma'am,
correct terminology used?
Ma'am, due to the duct-like cells which were present, it is resembling somewhat to some extent of ameloblastoma. In ameloblastoma, the nucleus is towards the lumen, which is away from the basement membrane, giving a tombstone appearance. But in
Sorry
this,
to cut you. I'm not saying that, but this is the old terminology, no more used. Okay, just want to
okay,
update you.
okay,
That's it. Okay, that's
okay.
it. All right. Okay, thank you. Yeah, thanks.
Shall I move to the next presentation?
Yes, yes.
Yes, please.
0016.
Yes, ma'am.
Yeah. Please start the presentation.
Okay. Good evening, all. Today I am presenting a histopathological journey of a radiculocyst, which explains how a normal developmental remnant can transform into a pathological lesion. So the journey begins from Hertzwig epithelial root sheath, so which I have shown in my first diagram. So Hertzwig epithelial root sheath plays an important role in root formation during tooth development. After root formation is completed, this should disintegrate. However, small epithelial fragments do not disappear completely. These remnants persist within the periodontal ligament. So these remaining epithelial fragments are the origin for future pathological transformation. So the foundation of the radiculocyst begins not from pathology, but from a normal development. So next, my second diagram shows that the dormant cell rests of Malaise. The epithelial remnants of Hertz are also known as cell rests of Malaise. In normal condition, these cells remain dormant and inactive inside the periodontal ligament. They do not cause any problem. They are biologically silent, resting peacefully around the root. However, they have the potential to proliferate if stimulated. So they are silent but not powerless. In my third diagram, they are activated, that is, they got stimulated. When there is a pulpal infection or periapical inflammation, inflammatory mediators stimulate these dormant epithelial cells. They begin to proliferate. As proliferation continues, the central cells undergo degeneration due to lack of nutrition. So this cavity becomes lined by stratified squamous epithelium. This results in the formation of a radiculatus, which is the most common odontogenic cyst. My first diagram shows that the formation of the cell rest of malaise, under which is dormant in the second diagram, and which gets activated and forms a radiculocyst in my third diagram. Thank you, ma'am.
What is Hertzwig's epithelial root sheath? Very basic.
Yes, ma'am. It was formed by inner enamel epithelium and outer enamel epithelium during root formation, which plays a crucial role in root formation.
Right. So its remnants they call are causing the radiculocyst formation. Right. Now, what is a bassist?
Ma'am?
Bassist. Bay.
Sorry.
B-A-Y. Bay.
I'm first year student, ma'am. I didn't hear this term.
Oh, but you answered about the HERs very nicely. That's good. No problem. Good.
Thank you, ma'am.
Judges, any other questions?
You referred organs for this?
Yes, ma'am. For
Okay.
histology, we are using organs, ma'am.
Okay. And what you want to
Shall I
show
move
by
to the
this?
next?
Ma'am?
Role of this toothbrush and all these teeth in radicular cyst?
That is border, ma'am, just to outline.
Design it.
Yes, ma'am. Yes, ma'am.
Okay.
It's an extra outline.
Okay. Nice presentation.
Thank you, ma'am.
Shall I move to the next presentation?
Yes, Shivani, you can move.
I request all the participants to stay back and motivate all other batchmates also. And just don't finish up your presentation and leave. Double 017. Are you there?
Yes, ma'am.
Yeah. Please start the presentation.
Good afternoon to all present here. Thank you for the opportunity to present my drawings and to explain about it. Today, the topic is about the dental complex, and I'm currently doing first year videos by analoging the dental pulp complex with the royal palace. Imagining the tooth as a grand palace and the pulp as a royal family living inside. Just a palace has a different areas which are organized with the different zones and have a special role for the functional, nutritions and the defense areas. The outermost zone, the odontoplastic zone. The palace guards like a odontoplast that are guarding the pulp cores, which helps to keep the tooth strong and safe. The next, cell-free zone. It's also known as the zones of Wade. This area is like a more like a courtyard where which may seem empty but helps in the more like a royal messengers where it has the nerve endings that helps to pass the sensitivities. Then comes the service zone. They have the busy administrative officers like the defense cells and more like reparative cells that helps when the pulp is repaired and to help in the defensive when it is injured. Here comes the pulp core, the royal throne room, where the blood vessels are like the king and queen, present to help the nutrition and the sensation of the tooth that controls the whole kingdom. So just like a well-organized royal palace, the pulp has different zones working to protect, nourish, and maintain the tooth. Thank you, ma'am.
You could have named this the poster Dentine Pulp Complex in bracket Game of Thrones. I mean, it's so well designed.
Thank you.
Cartoon Network in whole cavity.
Yeah,
Good.
correct, ma'am.
Actually, you kept your entire creativity here.
Cartoon Network. Good.
Well done.
Thank you, ma'am.
Any
Hi,
questions
Madhu.
from judges?
Hi, Madhu.
Shall
Thank you
ma'am?
for
Yes,
your
ma'am.
presentation. Yeah. Hi, Madhu.
Hi, ma'am.
Hi, I thank you for your presentation. I really like your analogy. Okay, I just want to, what is plexus of Rashko?
Plexus of Rashko's nerve fibers, which are myelinated nerve fibers, which are loses their myelin sheath that forms seen in the adjacent to the cell-rich zone in that's called the parietal layer that helps in the
Okay, yeah.
sensitivity.
Okay. Good. Yeah, that's all
Thank
from
you,
my
ma'am.
side. Okay, all right, good.
Yeah, good
Can I
evening,
move to the next
everyone.
presentation?
Dr. Shivani, just a small interruption. You have
Yes.
already announced that all the participants should stay back. Just see
Yes,
if
sir.
anybody has left, kindly note down the number. And I request everyone to please sit in a uh, in a in a room, not in a hall, because some voices are echoing, and should have a good internet connection. So I think all participants are clearly audible to everyone, or did you face any issues pertaining to that?
Good,
Dr.
I'm
Shivani,
good.
I'm asking you. What is the review of the judges and Dr. Kiran?
Not much problem, sir, actually. Yeah, some students actually little bit voice was feeble, but
Okay.
it was not a problematic. We can
Yeah,
able
yeah,
to
Yes,
fine,
sir.
see. Yeah,
fine.
yeah.
Just checking with everyone. So okay, fine. Everything is going smooth, and yeah, nice creativity and nice questions by the judges. Please carry on. I'm with you at the back end. Thank you so much. Please continue, Dr. Shivani. Please continue.
Thank you, sir. Yes. Yes. Next presenter.
I'm present, ma'am.
Yeah.
If my voice is audible, ma'am.
Kindly stand. Yeah, it's audible. You
Good
can start.
evening to all respected judges present here. My topic is the combination of cyst and tumor I have drawn here. It is just calcifying odontogenic cyst and the tumor is calcifying epithelial odontogenic tumor. I just want to say why I have combined these two cyst and tumor in this diagram is it charts the similar features like odontogenic origin. Both the cyst and the tumor originate from the remnants of the dental lamina and the stratum intermedium of the enamel organ. And this shows similar calcification is seen in both CEOT and COC. CEOT we can able to see the Leydig ring calcification, and in COC we can able to see the ghost cell calcification, and it charts the epithelial characterization like proliferation of the abnormal epithelial that mimic the stellate reticulum found in the enamel organ. I just want to say the what diagram represented. The circle, outside circle, I have divided the circle into three. I have represented the ghost analog that for COC and the histopathological feature of CEOT, and I have mentioned the parts of the each cell features, and higher magnification shows the prominent intercellular bridge and amyloid deposit that present. And also I have shown the apple green color bifurcations of amyloid deposit that present in the fiber connective tissue for the photomicrography of the CEOT. And in the left corner, I have shown the ghost cell feature that is the lumen that lined with the tall columnar epithelium that arranged away from the basal nucleus is arranged away from the basal lamina. And it is arranged with the stellate reticulum and the ghost cell. The main ghost cell feature doesn't have a nucleus, so it is anucleation, and it forms the keratinization of the aberrant abortive enamel matrix that is present, and it is calcification is seen. The main controversial going in COC, that is whether it is called as a cyst or it is tumor, that is a histological tug of war controversy going in oral pathologists, and it is a favorite topic of the oral pathologist whether they consider a cyst or a tumor. The WHO classification has classified as 1992 they have classified as cyst because it doesn't show any neoplastic development and neoplastic future. In 2005 they have named as tumor because it shows the neoplastic potential and solid lesion that is present, so they named as tumor. And in 2017 to 2022, they again consider as cyst because whatever may be the cyst or the tumor, its behavior decides its management, and it may be said it is whether it is cyst or the tumor. The cyst doesn't have any neoplastic future, but the tumor that shows neoplastic features like ghost cell or the amyloid like deposit that is present in CEOT. That's all, ma'am. Thank you.
Thank you so much. It's an amazing drawing, I must say.
Thank you,
It's
ma'am.
very creative. Judges, any questions from your side?
Yes, Nandini, it's very nice.
Thank you, ma'am.
Can you tell me any other lesions in which you get ghost cells?
I mean, amyloblastoma and amyloblastic fibroma, odontoma, and dentinogenic ghost cell tumor and non-odontogenic tumors is also seen, ma'am. But recently, in current status, it is mentioned as ghost cell odontogenic tumor for COC, ma'am, because it mimics the features of amyloblastoma.
Okay, any ghost teeth?
Ma'am?
Is there any terminology ghost teeth, like ghost teeth?
I'm not sure about it, ma'am.
You are third year student?
Ma'am, I'm doing internship, ma'am.
You are?
Internship, ma'am. I'm doing internship.
You are intern.
Yes, ma'am.
So is there any terminology like ghost teeth?
I have heard about the term, but
You can't recollect.
At
Okay.
point, I'm not able to tell, ma'am. I have heard about the term, ma'am.
Okay. Okay, nice drawing.
Any other questions? Can I move to the next presentation?
Yes, Shivani, you can.
Just a moment, please. Double 021?
Yes, ma'am.
Yeah. Please start.
Good evening, respected judges and my fellow participants. I am Vishmita Sandal Kumar, a first year BDA student at SRDCH. On this honorable occasion of National Oral Pathologist Day, I feel privileged to present my drawing on pulp stones. We are familiar with gallbladder and renal stones, but how often do we hear about pulp stones? Pulp stones are also known as denticles. These are calcified nodular structures seen in the coronal pulp. They are classified as free, embedded, and attached pulp stones. Free pulp stones are present in the pulp and are surrounded by the pulp tissue. When the secondary dentin formation continues, these pulp stones get attached to the dentinal walls, forming the attached pulp stones. Whereas embedded pulp stones are completely surrounded by the dentin. Further, pulp stones are classified into true and false pulp stones. True pulp stones show dentinal tubules, and those that do not show dentinal tubules are called the false pulp stones. Now, moving on to the types of calcification, we have metastatic and dystrophic calcification. Metastatic calcification is the deposition of calcium salts in normal tissues due to elevated serum calcium levels, whereas dystrophic calcification is the deposition of calcium salts in dead or degenerated tissues, despite normal serum calcium levels. Renal stones are an example of metastatic calcification, whereas pulp stones are classified under dystrophic calcification. Next, the pulp stones appear as a well-defined radio-opaque masses, which are located inside the pulp chamber and they are not surrounded by the radiolucent halo. Pulp stones are usually asymptomatic, but they are clinically significant as they make the root canal treatment more difficult. Through this drawing, I aimed to clearly represent both the anatomical structure of tooth and the classification of pulp stones in a simple and visually understandable way. I use various colors to represent the structure of tooth in this diagram, and I used the HNE pencils to in the magnified circles to represent the histopathological view of the pulpal stones. Thank you.
Dear judges, any questions?
Can you tell me the clinical significance of this or the for this pulp stones?
Yes, ma'am. During the root canal treatment, they will cause the disturbance, ma'am, making it more difficult to continue it.
Okay. Any other? Okay. Nice drawing.
Yes, ma'am.
You
have drawn the tooth
very
shape
detailed.
nicely, very nicely.
Thank you.
Any other questions? Can I move to the next presentation?
Yes, please.
Double 023, you there?
Yes, ma'am.
Please start.
Good evening to everyone. Today I'm going to speak about the microscopic structure of the tooth. The tooth is not made by a single layer. It is composed of the different layers and different zones. The enamel is the outermost layer of the tooth crown. It is the hardest tissue in the human body. It composed of the 96% of inorganic materials, hydroxyapatite crystal. So that's why I'm representing the crystals formed in an enamel. Beneath the enamel, lies dentin, which forms the main bulk of the tooth. It contains uh, dental tubules, which extending from the pulp to the enamel dental junction. In my drawing, I creatively represent the tubules in a brick-like appearance pattern. At the center of the tooth is the dental pulp. It's a vital living tissues of the tooth. It resembles the heart of the tooth with a rich in blood supply, nerve supplies. And the pulpes are arranged in the different zones such as odontoblastic zone, cell-free zone, cell-rich zone, and pulp core, which helps in the sensory functions, nutrition, and dental formation. The outermost of the root surface is covered by the cementum, which help in anchoring the tooth, the surrounding alveolar bone, through which the periodontal ligament. This heart shows that even the small microscopic structures can create something strong, functions, and beautiful. Thank you.
Thank you so much for your presentation. Judges, any questions? I think no questions. Can we move forward?
Yes, we can move forward. If there are no questions, we can move forward.
Yeah. The next presenter, 0030, are you there?
Yes, ma'am, I'm here.
Yeah. Kindly start.
So, good evening, everyone. I'm Sushantika, third year BDS from Sri Ramakrishna Dental College and Hospital. So, I'm here to present my art, which holds the title Patterns That Speak, Epithelium Turns Artistic. So, an unspoken dream of amyloblast. As we all know, amyloblast is the second most commonest benign epithelial odontogenic tumor till date. And the reason for me to choose amyloblast is that I thought the vast and diverse epithelial pattern seen in the amyloblast would go well with the topic kaleidoscope of oral histology and pathology. So, which made me design a kaleidoscope of amyloblastoma, along with the factors that cause them. So, the picture majorly contains a form of conventional amyloblastoma, which are the follicular, plexiform, acanthomatous, desmoplastic, basal cell type, granular, and the hemangiomatous forms. The amyloblasts gather not to form enamel but to form problems. As we have been discussing the beauty of pattern in the amyloblastoma under microscope, it is ambivalent When we look into the danger it holds, it has a very high recurrence rate, local invasiveness, with time which turns into a metastasizing amyloblastoma or amyloblastic carcinoma. The gallery of amyloblastic islands are spread out in a hematoxyphilic background, which here I depict with the lymphatics and lymphocytes, the mode of spread of amyloblastoma. Thank you.
I must say, what a detailed presentation it was. I mean, like, I loved your drawing.
Yes,
Thank
very
you,
nice.
ma'am.
Just like it has print. Very nice.
Yeah, drawing is very nice.
Yeah, even
Thank
I
you.
like the drawing. Okay.
Yes.
You said it is the second most common tumor. So which is the first common? Hi, can you hear me? Hello.
Are you there?
Yes, ma'am.
Okay. Hi, Sushantika. You said this is the second most common tumor, odontogenic tumor. So which is the first common odontogenic tumor?
If you don't
It's
know,
okay
you
if you
can
don't know the answer.
Yeah, it's
Yeah.
fine.
Just say,
You
just say.
can just,
It's,
yeah.
it's fine. It's fine.
Yes, ma'am.
No problem.
Yeah,
Okay. Thank you, Sushantika. It's all right. It's all right. Okay. Next. Yeah. If anybody else wanted.
Any other questions? I'm moving to the next presentation.
Yes, please.
Yes, the next presenter, are you there? 0031.
Hello.
Yeah, you're audible.
Good evening, ma'am. Let me all take you to a jungle ride to view the wildness of the histopathological science. So here, isn't it fascinating to know that under the microscope, the pathology transforms into a whole world of patterns? So here I start with starry sky appearance. It appears in Burkitt's lymphoma, and here we can see the macrophages and lymphocytes, which resembles star-like pattern in a dark blue background. And then we have a antelope standing there. So in that we can see the staghorn pattern. It has pericytes surrounding the vascular channels. It has vascular channels of varying sizes. Um, then we have a fish in the pond. So it resembles the fibrosarcoma. And in that we can see the spindle shaped cells which are arranged in herringbone pattern. And we can also see the mitotic figures. Then we have a tadpole shaped pattern which reflects the cytology of squamous cell carcinoma, and it has a enlarged head which has hyperchromatic nucleus in it and a tail, and it contains cytoplasm in it. Then we have a crocodile standing there. It has a sawtooth appearance which reflects the sawtooth retiridges in lichen planus, and here the degeneration or disorientation of the basal layer occurs, which causes the formation of this retiridges. So as a defensive mechanism, keratin is produced, which causes hyperkeratosis, and we can see endothelial infiltrations all over there. Then we can see the ants going in a linear pattern or in a single row, which represents the Indian file pattern in the polymorphous low-grade adenocarcinoma. In this, the tumor cells are arranged in a pattern like a linear row or a single row. So it represents the Indian file pattern. I conclude by saying that in histopathology, every pattern is not coincidence. It is a clue waiting to be recognized. And here I thought of bringing the patterns with the animals so that we can easily remember all those things. Thank you.
Yeah. Very nice.
Very nice imagination and
Hmm.
presentation.
It is very creative.
Yeah, yeah.
Judges,
Creative.
any
Yes.
questions?
Even I liked it. Yeah. Very good.
Any questions?
She already has presented so many histology for the mesenchymal tumor and epithelial. I think we can proceed further, I think.
Okay.
Thank you, ma'am.
The next presenter, are you there? Pavitra?
Yes, ma'am. I'm present, ma'am.
Yeah. Kindly start the presentation.
Good evening, one and all. This is the diagram I have drawn to explain salivary gland neoplasm based on their cell of origin. Basically, coming to the microscopic structure of the salivary gland, it has acinar cells and ducts. Basically, the acinar cells are serous acini and mucous acini. Serous acini secretes the watery secretion, and mucous acini gives the mucus secretion. And involving the myoepithelial cells surrounding the acini, I have shown the myoepithelial cells which help in contraction and secretion. Coming to the ducts, I have illustrated the intercalated duct, striated duct, and excretory duct, which forms the ductal system transporting saliva to the oral cavity. What happens when this normal things start behaving like abnormal? Coming to the histopathological things, these cells forms different tumors involving pleomorphic adenoma, Warthin's tumor, mucoepidermoid carcinoma, and oncocytoma. Coming to pleomorphic adenoma, it arises from ductal and myoepithelial cells and is the common benign tumor. It shows, my diagram shows mixed pattern with epithelial and mesenchymal like areas, and it was arised due to some markers now and genetic mutations. And coming to the Warthin's tumor, it is also called as papillary cystadenoma. And my diagram shows papillary projections lined by some epithelium with lymphoid tissue in the stroma. And coming to mucoepidermoid carcinoma, it contains mucus cells, epidermoid cells, and intermediate cells, and is the most common malignant salivary gland tumor. This is the only one malignant tumor, and remaining all tumors are a benign tumor. And more pleomorphic adenoma and Warthin's tumor basically related to the parotid gland, and the mucoepidermoid carcinoma related to the minor salivary gland. And this is the diagram that highlights how the normal glandular architecture related directly to the origin of different neoplasms. And thank you so much.
Thank you so much. It was a very detailed diagram. It's very good. Any questions, judges?
Thank you, ma'am.
Good presentation.
Nice presentation, Pavitra.
Thank you, ma'am.
Any questions from the judges side related to the histology?
Can I move to the next presentation?
Yes, please.
Yes. 0041.
Yes, ma'am.
Please start the presentation.
Good evening, everyone. Respected judges, Team Popma, and my colleagues. The topic for my drawing is Galaxy of Odontogenic Tumors. In my drawing, I have represented different odontogenic tumors as constellation in galaxies, because just like star, each tumor has its own unique pattern, origin, as well as the histological appearance. I have divided the galaxies into three main constellations based on their histogenesis, which are epithelial, mixed, and mesenchymal. In epithelial constellation, the tumors are derived
purely from odontogenic epithelium, which include ameloblastoma, calcifying epithelial odontogenic tumor, adenomatoid odontogenic tumor. The very first ameloblastoma, which is characterized by ameloblast-like cells, which are arranged in palisading pattern with reverse polarity. Along with that, stellate reticulum cells are there. Next are adenomatoid odontogenic tumor, which is also known as two-third tumor because it is found in two-third of female. They are found in two-third maxilla cases, and they are mostly associated with two-third of impacted tooth. Uh, AOT shows duct-like structure, rosette patterns, and foci of calcification. In the center, I have shown calcifying epithelial odontogenic tumor, which is also known as Pinberg tumor, which exhibit characteristic Liesegang ring calcification. Along with that, amyloid-like material is also there. Next, we move to mixed constellation, uh, in which we have odontoma and ameloblastic fibroodontoma. Odontoma represent hematomatous lesion which has enamel dentin and pulp-like tissue, whereas ameloblastic fibroodontoma shows proliferating odontogenic epithelial along with mesenchymal tissue and calcified dental structures. Finally, we move to mesenchymal constellation, in which the tumors are arising from odontogenic epithelium as well as mesenchymal. They are derived from mesenchymal tissues. It includes cementifying fibroma and odontogenic myxoma. Cementifying fibroma shows cementum-like structure, whereas myxoma shows spindle-shaped mesenchymal cells in loose myxoid cells. Through this galaxy concept, I have aimed to make histology more visually memorable and conceptually clear. Each planet represents microscopic field, helping us to recall in diagnostic features. This artistic integration of pathology help us to understand the complex microscopic pattern into structure easy way, which with our already existing constellation knowledges. The source for this drawings were from Schaeffer's textbook and Manual of Oral Histology, Maji Josh. And I want to say that this drawing is fully handmade along with that background. And at the end, I will conclude my topic by saying, from cells that stray to pattern we discern, in this galaxy of tumor, histology help us learn. Thank you very much.
Thank you so much. It was a good presentation. Do we have any questions, judges?
Any questions, judges?
Not from my side.
Not from my side.
Okay. I think we are coming to an end. Yeah, ma'am.
I said, please proceed with the last presentation.
Sorry, ma'am. 0042.
Yes,
Are you
ma'am.
there?
Yes, ma'am.
Yeah. Please kindly start.
So, good evening to everyone. And since my presentation is the last, I hope to end it in a very short note. So, to begin with my presentation, it's called Coloring the Invisible. Like when a pathologist looks into a microscope, they color the invisible. They create and witness a sight that is so lively that each slide is a work of art in its own glory. It is a colorful world that is visible only to a very lucky few and a certain magic that only they can seem to create. Now, as a first year student, the commonest stains that I've been exposed to so far is the iconic duo, hematoxylin and neosin. It is the gold standard, yeah, but even the greatest have their imperfections. Now, it is quite the truth to say that I've been missing out on the true beauty of pathology, special stains. Now, talking about kaleidoscope, kaleidoscope represent colors. Colors in oral histology is special stains. And the first thing that symbolizes colors is a rainbow. And to start with the first color of the rainbow, we have red, Congo red. Congo red is a special stain which is used to stain amyloids. It is a linear diazo dye with great affinity to the beta pleated sheets of amyloids. It is used to diagnose amyloidosis. And moving on to the second color, blue, we have Alchin blue. Alchin blue is used to stain and identify acidic mucopolysaccharides, and alshin is a catatonic and copper-containing dye. It is used to determine pathologies such as mucoceles. And coming to the third color, violet, we have chrysal violet. Now, chrysal violet stains nissl substances in neural tissues, specifically the RNA. It is an aniline dye, and it is used to determine pathologies such as neurological lesions and neural tumors in the oral cavity, like neurofibroma or schwannomas, which actually have a very less common occurrence in the oral cavity. Now, to the last part of the color spectrum, we have Grocot's methenamine silver. It is used to determine or stain fungal organisms. It works by staining the polysaccharides in the cell wall of the fungal organisms. It is a hexamine silver stain, and it is used to identify pathologies such as fungal infections in the oral cavity, like candidiasis. And no such cell walls of fungal cells, which can only be otherwise very meticulously visualized through an electron microscope, can be so easily visualized using something as simple as a silver stain. And moving to the last stain, the complex stain, Mason's trichrome. And as the name suggests, it is a combination of three different dyes. It ranges from a color spectrum of green to orange, and it can stain structures such as collagen fibers, keratin, muscle fibers, and even nuclei. It is used to identify fibrosis present in the oral cavity, as well as differentiate between a myofibroma and a smooth muscle lesion. So I hope my presentation has made the versatility of special stains very clear, and I'd like to end my presentation.
Thank you so much. It was an heartfelt presentation.
Thank you, ma'am.
Any questions, ma'am?
All good from my side.
Thank you,
Any
ma'am.
questions? No?
No
The
questions.
title is very nice, Coloring the Invisible.
Thank you,
Yeah.
sir.
Yeah,
Thank you,
yeah,
ma'am.
yeah.
Nice idea.
Hmm.
Thank you, ma'am.
Yes, finally we have come to an end of this presentations. Thank you so much for all the students for joining us today. I would like to give the vote of thanks as the program has come to an end. I sincerely thank our respected President, Dr. Bhuvan Nagpal, for his visionary leadership and constant encouragement towards academic excellence and holistic learning beyond textbook. My heartfelt gratitude to our esteemed judges, Dr. Shelly Alora ma'am, Dr. Shipra Deshpande ma'am, Dr. Shelja Chatterjee ma'am, for their valuable time, fair assessment, and insightful guidance that truly enriched this competition. A special word of thanks to Dr. Kiran Jadhav sir for his continued academic mentorship and encouragement to all the undergraduate students. I also extend my thanks to Dr. Anuj for his dedicated coordination and smooth execution of the event. The most important congratulations to all the undergraduate participants for their enthusiasm, confidence, commendable efforts. Thank you everyone who contributed to make the UG Kaleidoscope competition a meaningful and successful academic experience. Thank you all. Thank you so much, student. It was like looking at all those drawing. I think all of you has created a itch to go back and draw again, open our old books and see what amazing work we all have done in our academic life also. Thank you so much for participating. I want all of your cameras to be on. Let's click a picture and remember this moment. Judges, kindly keep your cameras on.
Really appreciating presentations. Very nice.
Some ideas were really amazing. Yeah, I liked it.
Yes, ma'am. Dear students, kindly open your cameras. Let's take a picture. It's okay, it's for us. I think everybody's shy. Yeah, yes, you have done a good job. Yes, Madhu is joining. Divyashri, come on. I want everybody.
Dr. Shivani, I would like to inform that please stop sharing the screen And
Oh, yes, sir.
and please inform everybody about our upcoming conference also.
Dear students, we are conducting our second national conference, that is from 2nd October to 4th October, where we have poster presentations and paper presentations also. It's a national level oral pathology conference, and we have some international and national speakers talking about everything. We have workshops on phlebotomy, blood, FNAC and everything. It would be an amazing insight, and the fees is extremely affordable, which is around 500 to 600 rupees for the UGs. I want all of you, and your enthusiasm which you're carrying for this contest would be greater if you participate in posters and paper presentations also. The brochure, I will be sending the brochure also in that. And tomorrow you will be like the winner of this competition will be decided. And please give us 2 to 3 days time. We'll be getting back to you with the certificates of your participation. Yes. Shall we click a picture?
Congratulations, all participants.
Let's say cheese. Thank you, Shelja ma'am, for participating. I just took a picture. Thank you so much, everyone. Thank you, ma'am. Thank you, ma'am, for coming. Thank you, Shaili ma'am. Thank you, Shipra ma'am.
Thank you,
Bye.
chairpersons, judges, Shipra madam, Shaili madam, and Shailaja madam for your acceptance to be a judge for this unique competition. And
Thank you.
all
Thank you. It was a
students.
delightful
Yeah.
experience for
Yes,
me
yes.
also.
Yeah, yeah.
Thank
And
you,
thank you
everyone.
all dear
Thank you
students.
so much, Dr. Kiran sir,
Yeah, yeah.
Dr. Shivani, and all the esteemed judges for their valuable time and inputs. So I think we all should enjoy and practice oral pathology. Dr. Shivani, have you clicked the photo?
Yes, sir. Yes,
A
sir.
group
I did it.
photograph?
Yes,
Okay,
yes.
thank you so much. You also did
Thank you,
a
ma'am.
nice job of moderation. Thank
Yeah,
you
yeah.
so much for reaching out my work.
Thank you. It's
Thank
okay,
you.
sir. That's my
Okay.
duty.
Yeah. I request the judges to send their evaluation sheets to me so that we can finalize the winners.
Yes, sir, definitely.
Okay, by night I'll send.
Yes, yes, yes,
Tomorrow,
ma'am.
ma'am, tomorrow we are announcing the winners, ma'am.
Yeah.
By night I'll send.
Yes, yes, no problem.
Okay.
Yeah.
Thank
Thank
you.
you.
Bye, ma'am. Bye, sir.
Bye.
Bye, everyone.
Bye,
Bye,
bye.
everyone.